Humanities Grand Rounds with Dr. Ann Lyerly. My name is Kim Weed, and I'm an assistant teaching professor in the Department of English and Comparative Literature, and the co-director of the HIVE Lab here at UNC. And the HIVE Lab, along with Carolina Seminars, co-sponsors this monthly talk series, and we're just so delighted to have Dr. Lyerly with us today. So before we get into introductions and the talk, I'd just like to take a moment to go over a few instructions for the talk today. We are asking everyone to keep their microphones muted throughout the talk, and that will just help us minimize distractions and interruptions that might take place. And then throughout the talk, and especially after, to facilitate the most efficient Q&A period as possible, we're going to utilize the chat box today. So if you have a question for Dr. Lyerly, either during the talk or after, please type it into the chat. And then our fantastic RA and current MA student, Megan Swartzwager, will read through those and relay them to Dr. Lyerly so that we can get to as many of your questions as possible. My final order of business before we get started is to just let you know that we will be recording this talk and post it to the HIVE website and YouTube channel. It typically takes a couple of days for processing, but know that it will be available and I will send that out to everyone. Okay, so rather than introduce Dr. Lyerly myself, I'm going to hand things over to Emily Long, who is a first-year medical student here at UNC, but also an alumna of our English MA program in Literature, Medicine, and Culture, and the past organizer of this series. So Emily, thank you so much. I'll hand things over to you.
Thanks, Kim. It's my pleasure to introduce our November Health Humanities Grand Rounds featured speaker, Dr. Ann Lyerly. Dr. Lyerly is a professor of social medicine and a research professor in obstetrics and gynecology at UNC School of Medicine. She is also the associate director of the UNC Center for Bioethics. Dr. Lyerly wears many hats in the School of Medicine, from teaching within the social and health systems curriculum to researching the meaning-making that is central to the remembered childbirth experience. Some of her latest work is within her role as PI on the NIH-funded PHASES project, which released a set of guidelines for the equitable inclusion of pregnant women in HIV research earlier this year. I first encountered Dr. Lyerly's work while scrolling through the New York Times and stumbling upon an article about the parenting column's decision to avoid the term natural birth due to its insinuation that the experiences of women whose births involved medically necessary intervention or pain relief were somehow unnatural. As a fledgling doula, I was captivated by the article, which addressed some of the questions that my time on the L&D floor had catalyzed. What was truly important to mothers, and how could I act on this information to empower them to have the experience that was best for them? How could one balance the dichotomy between autonomy and health outcomes? And indeed, was it even a dichotomy at all? Imagine my delight when I discovered that the main consultant of the article, Dr. Lyerly, was practicing right here in Chapel Hill. As Dr. Lyerly so persuasively demonstrates in her book, A Good Birth, Finding the Positive and Profound in Your Childbirth Experience, the birth experience that patients and providers should work together to achieve is not a natural birth, but a good birth. Through a meticulous 3-year study that elicited the stories of 101 women with a combined 196 birth experiences, from hospital births to home births, Dr. Lyerly investigated how women derived meaning from their birth experiences. As she argues, the birth outcome that women want is not simply the healthy mother and baby that medical quality control metrics thrive on, or the intimate hospital and drug-free birth experience that natural birth proponents laud. Instead, Dr. Lyerly went straight to the source, asking the mothers themselves what was truly important and deriving 5 tenets that are central to what she defines as a good birth: agency, personal security, connectedness, respect, and knowledge. As Dr. Lyerly writes, our births won't be perfect or meet an idealized notion of the good, but therein lies our humanity, and that, I would argue, is where we find beauty and meaning. The imperfection doesn't mean that all will unravel, but rather that we are firmly in the world. The goal is not the ideal birth, not the perfect birth, but the good birth. Today, we are fortunate to have Dr. Lyerly join us to talk about a topic that is particularly pertinent to the lived experience that we're all sharing from at least 6 feet apart, the coronavirus. Indeed, her talk is so cutting edge that its subject had not even entered the public consciousness when I emailed her to schedule this talk, which was originally set for April, but postponed due to COVID. We're grateful that we were able to reschedule and excited to hear Dr. Lyerly's exploration of the ways in which the pandemic has made visible the extant tension between the public and private spheres and how these forces can impact pregnancy and the individual choice to bring a child into the world. Please join me in extending a warm welcome to Dr. Ann Lyerly.
Okay, so now I should share my screen. Well, first of all, I feel very warmly welcomed. Emily, that was a really beautiful introduction and a really beautiful summary of my book. And I love talking about my book and what I learned from women about what constitutes a good birth. But I did, request to make a bit of a pivot today because I have some new things on my mind that I wanted to share, and I thought that this was a really wonderful forum to start building them out in. So I'm going to get my first slide up here. Let's see, how do I do this? Screen, share screen. This. And like that. Oh, whoops. Sorry, guys. Share. Okay. Does everybody see that now? Yes. Okay, good, good. So I want to really thank Kim for making this possible, and I'm really grateful to be here. I also just want to say that I recognize that this has been an incredibly, emotional week for a lot of people, and I'm very heartened to see how many people are here in attendance and ready to create some bandwidth and space to talk about something other than politics and something, very near and dear to many of our hearts. So the title of my talk is Pregnancy, the Pandemic, and the Morality of Reproduction. And usually when people evoke the morality of reproduction, what comes to mind is abortion. And when people think about the morality of abortion, the focus often settles on the moral status of the fetus and how women's decisions to reproduce or not bump up against that status. So I want to talk about something different today. So I'm going to talk today about decision-making when there's not yet a fetus, if only in the glimmer in someone's eye, right? So decision-making before conception and decision-making in the context of risk, which women do all the time. But we are in a moment now where that risk is more vivid, more widespread, and more a subject of public consciousness. So indeed, the pandemic has invited a conversation that has bubbled up over the years, but I think requires a lot more thinking and writing. And so I'm glad to sort of introduce the topic to you all. Let's see. Advance my slides. Let's see, I'm not quite sure how to advance my slides here because it's not quite going. Sorry, maybe if I click right here. There we go. You seeing the second slide? Okay, good. So if you guys are like me, this is a slide that is familiar to you. I look at it most days. It is the New York Times report of COVID. This is a slide from yesterday, screenshot from yesterday, reporting that in the US there are more than 10 million cases and almost 240,000 deaths since March. You'll also notice, and I'm sure all of you know, that there is a upward trajectory, which is concerning for all. In addition to this, increase in COVID cases and deaths, has been news in the last week that has provided some clarity about the impact of COVID on women who are pregnant. So in the beginning, it wasn't clear that COVID posed increased risk for pregnant women, which was actually quite surprising and reassuring. But data out of the CDC recently revealed that pregnant women are at increased risk for being admitted to intensive care units, for being intubated, and also for death. They also reported in a separate study that there's higher rates of preterm birth, so poorer outcomes for children. You also may be aware of many stories that have been effectively shared in the media and in other spaces about the ways that COVID affects the experience of childhood, the way it imposes on models of the good birth, whether it's not allowing doulas into delivery rooms, women being separated from their partners or indeed their babies, and the fear and uncertainty that has characterized many births in the context of COVID. So I think these things together have raised the question, certainly for women, but also for clinicians, and interestingly for public health officials, not just what to do to make sure that outcomes of pregnancy are as positive as possible, but whether it's a good time to have a baby in the first place, right? So raising questions about the, not just the practical, but the moral contours of decisions about whether and when to have a baby, and whether other people besides women should have a say in that. So anticipating this question, earlier this summer, a couple of colleagues and I got together. Denise Jameson and Sonia Rasmussen are both physicians who worked for decades in the Centers for Disease Control. And in the context, and they were repeatedly faced with pressure to advise, as public health officials, to advise women to avoid pregnancy or delay pregnancy in the context of pandemics. Fortunately, these women were in power, and they resisted those calls. But they felt like there wasn't a framework that sort of spoke to their intuitions and their arguments around not providing that kind of advice. So we got together and wrote a paper that's just coming out this month, which answers the question, I think, or at least begins to answer the question, whether public health agencies should recommend that women avoid pregnancy during a public health emergency. Why or why not? And if so, under what conditions? Excuse me for 1 second. So like I said, I think the paper that we wrote is sort of the beginning of a framework for it, but I think it invites a lot more inquiry, and I invite you to think about the ways that you can expand on some of the ideas we have here. But I wanted to start by sharing them. But the first thing I want to do is I want to take you through sort of past pandemics and what the public health response has been. So the first time the question came to public consciousness about whether public health agencies or other public institutions should advise women against pregnancy came in the early days of the HIV epidemic. So in those early days, HIV was very, very uncertain and very, very scary, right? So women who were living with HIV had about a 1 in 4 chance of giving birth to a baby with HIV before the advent of antiretroviral therapy. So 1 in 4 chance. Those women also had a very high likelihood of dying when their children were young. And furthermore, the women and the children both were at very high risk of an early and very painful death. Some of my most vivid memories from my early days in medical school were on the infectious disease ward with children infected with HIV. So given these facts, the Centers for Disease Control, this was prior to Sonia and Denise being there, issued a statement in 1985 that infected women should be advised to consider delaying pregnancy until more is known about perinatal transmission of the virus. To many people at the CDC, this seemed like a no-brainer. This seemed like a wise bit of caution. If you sort of read the conversations, and I know some of those people, they're very well-intentioned folks. But this advice led to a lot of concern. It led to concern about moral censure of women who went ahead and had babies who had HIV, about discriminatory policies, about coercive practices and the like. So in response to that, a multidisciplinary working group was formed at Johns Hopkins with colleagues of mine. Again, this was kind of before my time. And they deliberated over the course of a couple of years. And they did not endorse any directive from public health agencies. Instead, they endorsed what they called contextualized counseling toward reasoned and reflective decisions about childbearing. And notably, such decisions did not preclude going forward with getting pregnant and giving birth to a baby in the context of untreated and untreatable HIV. I think it's worth noting, and this was actually sort of my inspiration for much of my work going forward, and including the Good Birth Project, is that while they had amazing experts and scholars on that committee, they were most profoundly informed by a series of interviews with women from East Baltimore who were living with HIV and had been interfacing with these decisions about whether and when to have a baby. And sort of in Emily's words, offered the ways in which their decisions about having children or not held deep meaning for them. And also how their life context informed that. So just to say, you know, the expertise and the moral considerations that were relevant to those women shaped the and deeply this advice from this expert working group. So to some extent, I think after that, the case was settled for a bit. There was not much literature on it, not much conversation about it, until 2009, the influenza pandemic in 2009, which I know this is sort of a lighthearted picture, but it's called the swine flu. And I just think this picture always makes you remember what we're talking about anyway. So the swine flu was remarkable for its incredibly severe impact on pregnant women. So people in the context of this pandemic were worried about spikes in maternal mortality rates because it affected pregnant women so directly. Pregnant women were among the first to die from the pandemic. And ultimately, when the data were all collected, pregnant women were at, we learned that they were at higher risk of ICU admission and death. And while they constituted 1% of the infections, they constituted 5% of the deaths from H1N1. So at that time, my colleagues were at the CDC, were pressured to advise women to avoid pregnancy until the pandemic was over. But noting the fact that there were ways to prevent H1N1, that there were effective treatments against it, and that there was a vaccine on the horizon, the recommendation from the CDC was that pregnant women or women who were thinking about getting pregnant be educated on how to prevent infection, the importance of early treatment, and the need for vaccination. So next came Zika, and that was in about 5 years ago. So Zika was or is a virus that causes mild illness usually in adults. But when women are infected with Zika virus, they have an increased risk of having a baby with a severe congenital anomaly, most notably something called microcephaly. So this is a baby born to a woman who had Zika, and you can see that its head shape is much smaller than you would expect a newborn's head to be. So there were spikes in the rates of this condition in newborns, and that's how they kind of figured out what was going on. So in the end, it was shown that pregnancy was associated with an increased risk of severe congenital abnormalities of between 5 and 10% in the United States. It varied depending on what territory you got Zika in. And again, there were very strong calls to advise women to delay pregnancy in the context of Zika. And again, the CDC resisted those calls. And there was actually quite a strong debate in the New York Times about this. The CDC instead said women and their partners thinking about pregnancy should take precautions to prevent themselves from Zika, which included avoiding mosquito bites, which is how you got Zika, and using condoms, which was the other way you got Zika. If you had sex with somebody who was infected with Zika, you could get it that way. So that was somewhat laid to rest here, but with some residual concern. So now here we are with COVID, and I think this is just a beautiful picture. I stole it from the CDC website. I hope that's all right with them, but I just want to make sure that that's where it's from. So as I mentioned before, pregnant women are at increased risk of admission to intensive care units, invasive ventilation, and death. And we know that perinatal transmission probably can happen, but it's rare, and that there is increased risk of preterm birth and admission to the neonatal intensive care units. So again, raising the question about whether public health authorities should advise women to avoid pregnancy in this context. So, as we think about COVID, the question about what pregnant public health agencies can advise has really come under some scrutiny. Can they advise us to use a mask? Can they advise us to socially distance? Can they advise us to not assemble in certain in groups with certain numbers, right? So all of these so-called, personal freedoms have been challenged by the COVID pandemic. But, I would offer that reproduction is different, right? So as has been argued over decades, the exercise of public authority in a space that is so personal and private as reproduction requires strong justification because, and especially because of the ethical issues it raises. So for the next piece of my talk, I'm going to talk about some of the ethical considerations. This is kind of a new fleshing out that I've done. We really went through it very quickly in the New England Journal piece. And there are probably other ways to think about this, but these were the most pressing issues that came up for me. But before I get into that, I just want to have a little caveat here that that context matters. And what I mean by that is that what we're talking about is public health advice, public advisories. there's a different space that people are more used to thinking about when advice about pregnancy avoidance is offered, and that would be like in a clinical setting. So we are cautious about giving that kind of advice in clinical settings. I mean, particularly when the issue is something like counseling about a genetically transmissible disease, right? So in general, we have tried to adhere to a context of non-directive counseling, although I know not all doctors do. I mean, as I've written in my book, I've had 5 C-sections, and whenever I tell people that, I'm often told, well, my doctor, I've had 2 C-sections and my doctor said I couldn't have any more pregnancies, which is just not true. I mean, the doctor may advise a person that it would be hard for them to do a 3rd C-section, but there are varying degrees, varying spaces that different doctors are willing to go. I think in the OBGYN context, I think there are a few accepted areas where advice against pregnancy occurs, which pertain more to maternal health issues. So there are some women that have health conditions we mentioned in our article, Marfan syndrome with a dilated aortic root, for whom pregnancy raises their risk of death by a lot, right? There's certain conditions that that women have a 1 in 3 or a 1 in 2 chance of dying when they give birth. So I think there are many clinicians who think that those women deserve their advice not to get pregnant. But public health contexts are a very different story. And so when I'm discussing these ethical considerations, I'm mainly talking about public health context. But again, I think there's a paper to be written about clinical care here too. Okay, but we didn't write that yet. Okay, so what are the ethical considerations that I think are, most important, most relevant to the argument that public health authorities should not or should be very careful in offering this kind of advice? So the first is reproductive autonomy. So in general, in medicine, respect for autonomy is a guiding principle, right? So some people call it the most important principle, although others evoke justice, but we are going to go there a little bit later too. So reproductive autonomy tends to be prioritized given the ways in which decisions about childbearing bear on a person's, self-determination, notions of personal security and life course. Moreover, efforts to coerce women and men not to reproduce are considered among the most egregious ethical violations, right? Compulsory sterilization, etc. So some people might say, well, just public health advice against pregnancy does not in itself amount to coercion, right? It does not necessarily in itself undermine reproductive autonomy, but I think it's important to note that public health recommendations to avoid pregnancy may do so in a number of ways. For one, they may invite inappropriately directive counseling in clinical settings. So this is one of the things that was seen in the HIV context. So after the CDC offered that advice, which I think was kind of gentle about, maybe you should delay pregnancy until more is known. A number of public health departments instituted much more restrictive and coercive policies. They can also lead to restricted access to reproductive services important or necessary to reproduction. So my colleague, Marielle Gross from Hopkins just published a very nice paper in the Hastings Center report talking about the way that many reproductive services were being categorized as elective, whether that is contraceptive counseling, surgery for fibroids, infertility treatment, et cetera, when the people who are the consumers of these procedures do not consider them elective at all, and the ways in which that was undermining women's reproductive autonomy. So you can imagine the ways in which a public health advisory could translate into restricted access and restricted choice for women. And third, of course, is that these recommendations could lead to autonomy violations and punishment of pregnant women, as have occurred in the past. So what we have seen many, many times is that when there is advice, public advice, whether it's about not using drugs or alcohol in pregnancy, professional guidelines about optimal mode of delivery, like whether somebody should have a VBAC or not, and even unsubstantiated guidance about bed rest, when women do not follow this advice, they have been forced to undergo treatment, and in some cases they have been punished or imprisoned or lost their children. So this kind of advice is very, very powerful, and it has a possibility, it has a potential to have a restrictive impact on women's reproductive autonomy. Okay, so that's my sort of first set of ethical considerations. Then the second has to do with policies, discriminatory policies. And here I'm evoking justice and really reproductive justice. And reproductive justice deserves more than a mention and more than a slide. It's a really important framework for thinking about reproduction, reproductive ethics, really, that was founded by a group of Black feminists, but really talks not just about the importance of decisions not to have a child, right, in terms of reproductive rights, but the importance of the ability to have a child in an environment that is safe and conducive to healthy parenting and healthy growth of children, right? So I hope I didn't butcher that description of reproductive justice, but I think it's important to set the stage. I should have had a bullet on that at least. But the notion is that objectively neutral policies can translate into differential experiences according to race, ethnicity, and social class. So one of the problems that has been noted and sort of made very vivid by individuals in the social scientists is this idea of stratified reproduction. And stratified reproduction is the fact that some women's childbearing has been devalued compared to others, and that objectively neutral policies need to be examined for their differential effects on people according to race and socioeconomic status. So I think a very beautiful example of stratified reproduction is in policies around LARCs, which are long-acting contraceptives. So efforts have been made to make them widely available and free of charge. And so on the face, that seems like a good thing, right? But the problem with that is that LARCs, which are either an IUD or an implant, also need a doctor to take them out, right? And so the problem with LARC policies was that while they offered provision of these very, very highly effective contraceptives, a person would have to pay to get them taken out. So women who did not have those access to that, to insurance or medical care, would be stuck with contraception that she didn't want. And moreover, the draw of free contraception would turn some women away from a contraceptive like a pill or a patch, over which she had much more control. So it's just important to think about the ways that a certain policy may differentially impact according to race and socioeconomic status. It's not hard to imagine how advice against pregnancy and COVID would have this kind of effect. The third set of considerations that seems important to consider is something I call blame shifting. So advice to avoid pregnancy may inappropriately shift responsibility onto mothers and fathers and away from responsible institutions and entities. So the fact that we have a flaming pandemic right now is not any single woman's fault, right? The fact that she is considering a pregnancy in the face of risk is very real to her, but she's not responsible for that, right? So I think there's a beautiful paper in the journal Nature written by Sarah Richardson and colleagues. So this is a pretty prestigious science journal. And they coined this term mother blame, which is the tendency to focus on maternal behavior to the exclusion of broader environmental factors. And it may result in blame, punishment, or policing, just sort of like I mentioned before. There are many examples of this in the past. The blaming of mothers for autism because of the way they were not emotionally warm enough. The blaming of mothers for criminal tendencies in children because of them being nervous during pregnancy or because of the certain company they kept. And then newer data that explore the developmental origins of health and disease. So what happened before birth that can explain health and disease now, right? So pretty scientific explanations, but the absence of conversation about the broader environmental context and thinking about the woman's body as the environment has led toward blame rather than appropriate problem solving and responsibility being placed in the hands of the people who are empowered to make a change, right? Whether it be in the environment or whether it be in the pandemic response. Okay, so am I doing okay for time? Yeah, okay.
Yeah, we've got about 22 minutes left. So yeah,
Okay.
you're great.
Wonderful. Okay, so the fourth sort of consideration that argues against advice around pregnancy avoidance has to do with the disability rights critique of many things. As the disability rights community has really persuasively argued, advice about the avoidance of pregnancy, a pregnancy that may result in offspring with disabilities, may send a harmful message about what or who is valued. So this critique has been launched most forcefully in the context of prenatal testing, but I think it pertains to a number of other contexts where the thing that is what we are trying to avoid is the birth of a child with a disability, whether that's from preterm delivery or from genetic problem or environmentally determined, problem. Sorry. So I think the critical thing here is just this beautiful distinction that people in the disability rights community have made between preventing a disease, right? Preventing COVID by wearing a mask or social distancing, et cetera, and preventing the birth of a child with a disability. So prevention is not prevention, right? So those are two different kinds of prevention. And while, the argument holds most profoundly when the question of pregnancy termination is before us, I think it holds quite a bit of force even when we're thinking about getting pregnancy now, right? Getting pregnant now or later. Okay, so those are sort of the four ethical considerations that I think push us away from the public advice against pregnancy. So what might be a reasonable criteria for making such a recommendation, even in the face of all these ethical concerns? So again, Sonia and Denise and I had some conversations about this, and this is what we came up with. And I think it is an important start, but worth some debate. So the first is that the risk should be well characterized. So we, especially here in the United States, are pretty used to telling pregnant women to be careful based on our fears and based on theoretical risk, right? And I can go on and on about why this is problematic and harmful, but I think when we are up against the highly ethically challenging question of whether public health authorities should advise a woman not to get pregnant, theoretical risk is not enough. So the risk should be well characterized. Let's see if I can get to the second one. Second, the risk should be high and well above the risk associated with other common conditions and exposures. So, if we think about, higher rates of preterm birth in the context of COVID, or higher rates of congenital abnormalities in the context of Zika, objective observers are just thinking about that risk. But the fact is that women decide to pursue pregnancy in the context of risk all the time, right? Women with diabetes face higher risks of having children with congenital problems, with birth-related issues, and they also put themselves in harm's way, right? Higher risks of cardiovascular events and kidney problems. Some women with diabetes have a risk of going blind when they get pregnant, okay? But they pursue it anyway. Some don't, some do. Even women who have an increased risk of death may decide to pursue a pregnancy. So the fact is that women will decide to get pregnant, and they will be supported by their physicians and their families in their pregnancy, even if risk is there, and it is for everyone. Let's just be honest, right? So I think the risk level of COVID is not presently out of the range of risk that we are used to considering in the context of pregnancy. Third, the risk cannot reasonably be minimized or mitigated. So this was a really important counter argument for Denise and Sonia in past years, in that the risks of things like Zika and flu could be minimized and mitigated, right? And in COVID, we know ways to minimize and mitigate the risk of COVID. So a context where we might not be able to minimize or mitigate the risk would be something like a nuclear disaster, right? So that is one possibility where pregnancy avoidance might be justified as a public health recommendation. But here, where we know it's not easy, but you can do it, it seems like there are other ways, right? Effective contraception should be readily available. So, I think for criteria for almost anything, this is true. But in any context where the sort of moral contours of deciding to or not to get pregnant are being considered, the availability of effective contraception is a basic, right? And finally, there should be educational programming that lays out the risks and alternatives that is available and accessible to everybody. And that programming should be available and accessible to women as well as men. So those are our criteria for pregnancy avoidance. As you can tell from my sort of peanut gallery comments to myself as I was going through them, we do not think that COVID hits the bar that is needed for public advice to avoid pregnancy. But there may be circumstances, but this is not one of them. So let's see. So last of all, I just want to offer up some closing thoughts and then open it up for discussion. So I think over the last many years, what the ways in which I have learned about the salient ethical considerations and then offered guidance for public health officials, for clinicians, and for others is to listen to women and to understand the things that are most important to them, and to acknowledge and respect that different people have different life contexts, they have different values, especially when it comes to decisions about whether and when to have a baby. And so I think this is no exception to that rule. And I think we need to do a lot more listening before we offer advice. So that's my talk. I welcome any questions or comments. And again, I want to thank my collaborators for their input.
Wonderful. Thank you so much, Dr. Lyerly. Folks, please feel free to utilize the chat to type your questions. And then Megan can relay those questions to Dr. Lyerly. So we can give folks a minute to type and make sure they're ready to go.
Okay.
Well, I've got one to get us started. I was typing it, but I'm going to just take control and vocalize it instead, just because I haven't finished typing it yet. But wanted to thank you for this incredibly rich talk. And I'm starting to see so many overlaps in the ethical issues that you've raised today with some other places or other populations. So for instance, the blame shifting that you mentioned, I certainly felt like we saw that happen as students returned to campus, started to get COVID. So much of the blame was, well, it was the students' fault for, going to the party. It had nothing to do with the, living conditions in which they were returning to. Just for instance.
Yeah.
But I want to go back to something that you brought up fairly early in the talk about the comparative risk or the severe risk of COVID complications for pregnant women, especially when it comes to intubation and mortality. And I'm wondering how that relates to the racial disparities in maternal mortality risks more broadly. Especially given that so much of COVID is disproportionately affecting communities of color. Is there any relationship between those? I guess this is kind of a justice question.
Yeah. Well, I mean, I think the disparities have been marked, and I think the current, absent COVID, the disparities in maternal mortality and other obstetric outcomes are important and worrisome in terms of justice and need attention. And clearly, those disparities compounded by COVID and then compounded by COVID's disparities. When we put all those together, it's not surprising that the poor health outcomes for women who are pregnant with COVID are concentrated in the Hispanic, non-Hispanic, Black, and actually Pacific Islander populations. That's what the data are showing right now. So it is indeed a question of justice, and I think it is really worrisome. One of the things that I think, I wouldn't be the first to say this, but I think COVID has exposed, deep problems with maternity care, and one of those it is the it's made very vivid the problems associated with disparate, is made very vivid that what might be going on in terms of contributions to the disparate outcomes. So I guess I'm kind of talking in circles, but I think it is a consideration of justice, and I think makes even more important these questions when we're thinking about telling a certain population to avoid pregnancy when there is a disparity in the kinds of risks they will face compared to the other populations. So I don't know if that answered your question at all, but
Absolutely, yeah. I'll let Megan read. We've got a few questions in the chat. I'll let Megan relay those to you.
Yeah, first, Dr. Lyerly, I just want to say thank you for that really rich talk. It's definitely got my gears turning. But our first question in the chat is from Allison Nolte, who wants to know if you can talk a little bit about the ethical issues around limiting the number of...
I'm sorry, I missed the last part of your sentence. The ethical issues around what?
Limiting the number of support partners that are able to be present at a hospital birth.
Yeah, so I think it's really it's really important. So in the early days, there were some hospitals that actually limited the number of support people to 0. There still are some hospitals that limit numbers of support people. And one of the problems that has come up is that doulas, which the data show have been incredibly important in improving a number of maternal health outcomes in the context of birth, and certainly their experience, are considered support people and not healthcare providers. And so you have to choose between your partner and your doula. And that seems deeply problematic to me. And I think, again, there are also certain populations that are at higher risk of having their autonomy rolled over in hospital settings, right? And those are the very people at higher risk for COVID. And those are the people and so they are going to be going into the hospital without, their doula, without, maybe they need a couple of support people in there. The other issue that has come up, which I think is really problematic, is that some hospitals are saying that you can only have one support person and you can't rotate people out, right? And so if your partner has to go back to work and your mom wants to come in and support you, they say, pick. You can have one or the other, because we don't want those exposures. So again, somebody whose partner can take a week off of work, maybe isn't the one person who needs their partner there the most, I think, is what I'm trying to get at. So I think, again, we're seeing the ways in which, a policy that objectively is meant to reduce risk of getting COVID can disparately affect the people who are most at risk.
Megan, do you want to go ahead and ask the last question and then we'll wrap up?
So our next question is from Sadie Thomas, who asks, how should institutions be held responsible for blame shifting?
Great question. Well, I think institutions need to accept the responsibility, right? So it's sometimes the institution is the blame shifter, right? But sometimes it has to do with the way that recommendations are made and understood, with the way data are communicated, And so I think, you know, sometimes a responsible party who doesn't want to be responsible is not going to immediately accept that responsibility. But my sense is that there are places sort of in the communication chain that can highlight the ways in which, you know, those institutions are the responsible party. So, for instance, I think when we are thinking about what is an appropriate policy with regard to pregnancy avoidance, right? Telling women that they shouldn't get pregnant implies that they're the people who are responsible for the outcome, and it makes very much less vivid the outside environmental factors as what's at play, right? So I just think, you know, care needs to be taken in the way data are reported, the way that public health recommendations are made, the way that we speak, and the way that we, you know, sort of check the institutional responses to the poor outcomes, just the way Kim was doing in terms of the blame shifting around students, right? So call them out on it.
Squeeze in one more.
Okay, sure.
All right. So Alana Gilbert asks, how can we assert that women have all of the pertinent information needed to assess their own risks becoming pregnant during COVID, especially when pregnant women of color are disproportionately impacted by COVID, and these communities have been historically marginalized with inequitable access to education and medical information in general?
That is a great question. So I think it's a challenge for public health agencies and for doctors in communicating data effectively. I think that the Centers for Disease Control has worked to make their information for the public more accessible and less jargony and more streamlined. I think that's a really good question for, you know, some of our public health folks in the room and outside the room. But I think that the importance of education cannot be, underestimated. I mean, honestly, preconception counseling is an area that we haven't done very well with. And it's fraught for a number of reasons that I won't go into right now. But I think for women who are actively trying to make this decision, having a conversation with a clinician, offering clinicians guidance about what non-directive counseling should look like, et cetera, is an important step in the right direction.
Wonderful. Well, folks, we are right at 1 o'clock, so unfortunately we are out of time. I'd like to thank Dr. Lyerly one final time for joining us today. You've given us so much to think about, and I've got notes to pour over after this. So thank you, thank you. For anyone who's interested, I just want to let you know that looking ahead to next semester, we'll continue this talk series virtually. And probably sometime in December have a full announcement in terms of our speaker lineup. So please keep an eye on the listserv, and you can always join our listserv by going to the bit.ly HHGR email. I will put it in the chat so you have easy access to it. That way you can keep up to date on our events to come. So thank you so much, Dr. Lyerly, and everyone for coming out today. I hope you all take care.
Thank you.